This is a video in clinical medicine from the New England Journal of Medicine.
The placement of a central venous line is an essential technique in the treatment of many hospitalized patients. This video will demonstrate the placement of a central venous catheter in the internal jugular vein with the use of one of several variations of the Seldinger technique. An additional video on subclavian line placement will be forthcoming. We will demonstrate and review the regional anatomy of the neck, indications for the insertion of a central line, the recommended site and technique for placement of a line in the internal jugular vein, selected complications associated with the procedure and suggestions for how to avoid them, and appropriate care of the line after it has been placed. The placement of a central venous line is indicated for the continuous monitoring of central venous pressure, the delivery of critical or caustic medications, for emergency resuscitation, hemodialysis, and pulmonary artery catheterization. General contraindications for the placement of a central venous line include infection of the area overlying the target vein and thrombosis of the target vein. Site-specific and relative contraindications include coagulopathy. Although this is not an absolute contraindication, extreme care must be exercised in patients with coagulopathy and in other patients for whom complications would be life-threatening. After the procedure has been explained and consent obtained, review the records to confirm that there are no contraindications and examine the patient, concentrating on the regional landmarks. The internal jugular vein can be found at the apex of the triangle formed by the sternal and clavicular heads of the sternocleidomastoid muscle just lateral to the carotid artery. To assure that there is the highest level of sterility, the operator should wear a sterile gown and gloves, as well as a surgical cap, mask, and face shield. Most of the equipment can be found in commercially prepared kits, and should include skin preparation solution, sterile towels or drape sufficient to cover the entire body, 1% lidocaine, sterile 4x4 gauze, non-luer lock or slip-tip syringes, which are easy to remove from the needle, a number 11 blade scalpel, saline or heparinized flushing solution, a catheter with the appropriate length and number of lumens, a compatible skin dilator, usually 1 French larger than the line, an appropriate sized needle, a guide wire of compatible size, which will pass through the catheter and needle, suture, and a needle driver. There are numerous types of central venous catheters to choose from. 7 French triple lumen catheters of either 15 or 20 centimeter length are most commonly used in adults. For resuscitation or dialysis, large bore catheters are preferable, since there is less resistance to flow than the smaller bore types, allowing for much higher infusion rates, although large bore peripheral IVs often allow even more rapid fluid administration than central venous lines. For small adults and children, or for those in whom access to the jugular vein is difficult, 5 French and 4 French catheters can be used. If there are no contraindications, proceed by placing the bed in a 10 to 15 degree Trendelenburg position to decrease the risk of air embolism and to engorge the vein. Turn the patient's head so that the chin points away from the vein. Generally, the right internal jugular vein is preferred, since it provides a more direct approach to the superior vena cava. Remember, positioning is instrumental in the success of the procedure. Identify the triangle formed by the sternal and clavicular heads of the sternocleidomastoid muscle and the clavicle. Determine the location of the carotid pulse. The path of the vein runs just lateral to the carotid artery. The needle will enter the skin at the apex of this triangle just lateral to the carotid pulse, and will be aimed toward the ipsilateral nipple. Following these landmarks can be challenging in the obese patient. Ultrasonographic guidance is becoming the standard of care in the placement of a central line. It can help to illustrate aberrations in the anatomy, facilitate rapid placement of the central line, and decrease the risk of inadvertent arterial puncture. To identify landmarks with the use of ultrasonography, The probe is placed directly on the needle insertion site. The vein and artery are identified on the image as circular and black. The vein is identified by applying gentle pressure with the probe. The non-muscular vein will collapse easily, whereas the artery will remain relatively circular. Prepare the area by scrubbing the skin with chlorhexidine for 60 seconds and drape the site. Be sure to include all landmarks within the sterile field. If the patient is conscious, explain that his or her face will be covered, but that breathing will not be obstructed, and that he or she can signal for attention by raising his or her hand. Flush the lumens of the central line with saline or heparin, and ensure that the guide wire threads easily through your needle. Remove the cap from the port through which the guide wire will be threaded. This is commonly the longer lumen. If using ultrasound, prepare the ultrasound probe with a long sterile sleeve, being careful not to contaminate the sleeve prior to placing it on the sterile field.